All right. Hello, everyone, and welcome to another installment of your PS Platypus lecture series for this week. Today, we're going to be looking at one of the, or in fact, the last of the big three systems that you're going to be covering in semester one, which is the gastrointestinal system. And today, we're going to be focusing on the physical examination. So last week, you would have covered the systems review for the gastrointestinal system. Now we're going to try and support our evidence that we get from that history further by actually looking at the patient and the different signs that they're showing on their body. So let's get started. When it comes to the gastrointestinal examination, we kind of still follow the same steps that we did for cardiovascular and respiratory, although with the notable exception that instead of looking at the chest, we're now looking at the abdomen. So we still start with general inspection from the foot of the bed. We still start with vital signs. We then move on to the peripheral examination, same sort of protocol, upper limb, face and neck, legs, and a little bit of the chest. And then we go to the abdomen and we still follow the same 4 steps. So inspection, palpation, percussion, and auscultation. So we'll get started with general inspection first. Now, as always, you want to make sure that when you walk into the room, you introduce yourself to the patient, whether it's an OSCE or whether it's an actual clinical environment. You have to obtain consent, explain what the procedure is, what you're going to do, and then start with talking to them about the exposure that's going to be required. So with the abdominal examination, for the most part, you don't need to have that much exposure until you actually get to the abdomen, where you will require the patient to either lift up their shirt or take the shirt off entirely so that you can also have a look at the chest. So when we look at the general inspection, we're looking at the basic things like their mental state. Are they agitated? Are they in pain? Are they uncomfortable? We then look at their skin. Is there any signs of pigmentation, which we will cover some of the underlying causes of pigmentation a little bit later. But one of the major ones you can think about is jaundice, so any yellowing of the skin. Then you look at body habitus. So are they cachectic? Do they have a strange posture? Or do they have any skeletal deformities that are visible? And then you look for abnormal movement. So do they have any tremors? Do they have any agitation, as I mentioned previously? And then finally, for supplemental aids. So it's not too I guess, specific to the abdominal examination, but you want to look at the oxygen mask that they might be on, how critical they are, as well as the environment that they generally are in. So in general, when it comes to the general inspection, I think I said general there twice, but in terms of the general inspection, we are looking at 2 main facets of the patient. We're looking at external to the patient, which is the environment, and then internal to the patient, what's actually happening with them specifically. And then as always, all of the vitals are important. So you want to get every single one of them for the examination. But the main things that you're actually looking out for in your mind are signs of sepsis or perforation in an organ. And these will be things that are very typical, like tachycardia, hypotension, and whether the patient is febrile or not could give you a sign of sepsis. It does carry a very poor prognosis if it's untreated. So you really do want to make sure that you look out for these things quite early, and that'll dictate the management of the patient that you have. All right, now moving on to the peripheral examination, we first start with the upper limbs. So when we look at the hands and specifically at the nails, we're looking for things like leukonychia and Merkey's lines. Now, I'd encourage you to, like, whenever I say these terms, and some of them might be a bit new or seem a bit strange, it's definitely a good idea to have a look at these online, just so that you have an idea of what you're actually physically looking for, rather than going into the OSCE and saying, oh, I'm going to look for leukonychia, but then not really knowing what it looks like. So these 2 types of morphologies are actually signs of hypoalbuminemia, which is a potential sign of liver disease. You also have koilonychia, which is your spoon-shaped nails, and that's a classic sign of iron deficiency, which is important when it comes to anemia. You also have clubbing, which can be a lot of things. We discussed a couple of things in respiratory. We discussed a few things in cardio. But in gastro, we have it being potentially a sign of inflammatory bowel disease or liver cirrhosis. So if you do see clubbing in a patient, as you can tell, it's quite non-specific to any system, which is why it can support your evidence, but it doesn't directly give you a diagnosis. In fact, none of these signs will give you a diagnosis. It's more giving you an indication that I need to do this, this, and this for further investigations to rule out what I think could be causing these signs. You then have peripheral cyanosis, which could be potentially a sign of liver disease. When you see peripheral cyanosis, you're more thinking heart related. But the reason I put liver disease is because there's a phenomenon that links the lungs with the liver. And when you have some sort of liver disease, the lungs, I believe the arteries or the veins or something, they constrict, reduces the amount of oxygenation to the rest of the body. But it's a very, very rare condition. So I wouldn't be thinking liver disease off the bat. When you look at the palms, these are some things that might already be familiar to you. So erythema, which is a sign of potential alcohol overuse. You have pallor, which of course we know is anemia. You have tendon xanthomata, which is those cholesterol deposits that you find at the end of tendons. Dupuytrenine contractures, which you will see in the muscle bulk of the hands, that is associated with alcohol abuse disorder. Hepatic flap is potentially a sign of hepatic encephalopathy, where because your liver is unable to actually get rid of a huge amount of toxins, those toxins just enter the blood, and one of the major organs that it'll affect is going to be the brain. So you get encephalopathy as a consequence. And so it's not just going to be hepatic flap you see, it'll potentially also be things like them seeming really confused or agitated. Hepatic flap, just for context, is basically the same as asterixis. So you have them extend their arms out, cock their wrists back to 90 degrees, and then make them hold it there for about 15, 20 seconds. And if you notice that their hand sort of goes like this continuously, that's hepatic flap. When we get more proximally though, we're looking at the arms for just some general skin signs. So am I noticing any bruising, which could be a sign of underlying coagulopathies, which is slightly more relevant to heme. But if you think about it, the liver is actually responsible for creating a lot of these major clotting factors. So it could actually be a sign of these coagulopathies could be secondary to liver disease. You can have muscle wasting, which is again, not so specific to abdominal examination, but it can be a sign of malnutrition. And one of the major things in this context is in chronic alcoholics. So sometimes alcohol use disorder, it can be found in patients who just drink alcohol and don't eat anything else. And those nutritional deficiencies leads to muscle wasting. You can also have scratches on their arm, which is a sign of pruritus. It can be from jaundice, but classically, when you get to the renal examination, you're probably more thinking about kidney disorders. Then with spider nevi, again, have a look at this because it's exactly what it sounds like. You've got this sort of red spot in the middle, and you've got little red legs that come off of the central spot. And that's why it's called a spider nevi, because it looks kind of like a red spider. It's a type of telangiectasis. You don't need to know these terms. The main thing is that you want to differentiate these from other like rashes. So what happens is that when you press on the central spot, you should find that the legs of the spider will blanch or go away. And the reason why these spider nevi happen is still uncertain, but it could be a form of liver disease. And the reason why is because these liver diseases like portal hypertension leads to blood backing up into the spots where you've got portosystemic anastomoses. And some of the areas where you have these anastomoses is around the umbilicus, which we'll go over in a little bit of time. But the arm is also a potential site where you get that vascular congestion. When you look at the axilla, you can have a sign called acanthosis nigricans, which is, again, if you have a look at a picture, you may have seen this in patients before who have diabetes. So it's got these dark and waxy sort of shiny patches. You classically will find them in your skin creases. So I've put axilla here, but you can even find it in the nuchal folds, so the back of the patient's neck. Basically anywhere where skin falls onto skin is going to be where you can find this. And the classical sort of association is with insulin resistance. So as I said, in diabetes, this is a very common finding. Then when you look at the face, you're again following the same procedure of looking at the general face overall. So again, looking for jaundice, anemia, that kind of stuff. But then you move specifically onto the eyes. So I would have discussed how to look for scleral icterus and conjunctival pallor. So if you want to look for example, conjunctival pallor, you have the patient pull their eyelids down, or you can do this on them and then have them look up so that you can look at the whites of the eyes. The pink of the conjunctiva. And then a similar thing with scleral icterus. You have them pull up their eyelids, look down, you can see the whites of the eyes. And if they're yellow, that's a sign of jaundice. With gastrointestinal more specifically, you can have these things called Kaiser-Fleischer rings, which is around the pupil. You can see these, I guess you could say greenish gray rings. And that's supposed to indicate copper deposits, which is potentially a sign of Wilson's disorder, which is a genetic disorder where you don't have or you have excessive copper in your system. You can also have xanthelasma, which is similar to xanthomata in the tendons, but in this case, you have it around the eyelids, and it's a similar sign for cholesterol deposits. In the mouth, general things like halitosis, teeth, and dental hygiene, we kind of discussed why this is very important with infective endocarditis, but it can be predisposing factors for things like ulcers in the mouth. Leukoplakia, which is leukoplakia being this kind of white texture, this really white and scrapey texture to the tongue, that can be a sign of tobacco overuse or smoking. Atrophic glossitis, which is basically the tongue, like the taste buds, they atrophy off. So you kind of have this shiny, smooth tongue. And then angular stomatitis is where you've got the angles of the mouth, they become a bit deeper. So you get almost like you can see cuts on the sides of their mouth. And that's called angular stomatitis. So they both kind of indicate very specific deficiencies. But if you just want to think about it overall, whenever you see these signs, you're thinking about iron or vitamin B or folate deficiencies, which are very clearly associated with different types of anemia. And then finally, ulcers in the mouth. So they can be benign, what we call aphthous, or they can be related to other conditions like inflammatory bowel disease. And then finally, feel for the parotid glands. And if you have any enlargement, it could be an infective cause, so parotitis, or it could be because of actual alcohol use. So in someone who drinks a lot of alcohol, those parotid glands can also enlarge. And if you have other evidence that supports alcohol use, that can be something to think about. In the neck, we're doing a similar thing to respiratory examination. You're looking at all the lymph nodes in the head and the neck, the texture, the tenderness, make sure to describe them as you're going through. Remember, normally you shouldn't feel any of these lymph nodes. So as you're going along, it might feel a little bit strange that you're not really, feeling anything. But if you do feel something, that's a bad sign, because it could be a sign of infection. It could be a sign of metastasis. It could be a lot of different things. In particular for gastro, though, you are looking at the supraclavicular lymph nodes, which are labeled sort of at the bottom here, above the clavicle, as the name suggests. And the reason why these are important is because if you think back to the anatomy lecture that I gave, I would have posed the question about what is the first palpable lymph node when it comes to stomach cancer. This is the one. And the reason why is because, the stomach cancers and things like that, or just in general gut cancers, they drain into really deep lymph nodes. So even if you try to palpate, as deep as you could into someone's abdomen, you would not get anywhere close to those lymph nodes unless they were like really, really enlarged, which would be very worrying. It's only once it kind of drains all the way up to the supraclavicular lymph nodes, typically the left side rather than the right side, which we call Virchow's lymph node. That's where you have a very high clinical suspicion of a gut cancer. Okay, so that's the first lymph node that would be enlarged that you can actually feel. And then some extra signs when it comes to the rest of the body. So if you have a look at the chest, you can have spider nevi. So that's something that I would have mentioned before. But in this case, again, it's a very similar sort of pathology. Gynecomastia is where you have, again, have a look at a picture of this, but where you actually have breast tissue developing in a male patient, which is abnormal. So this could be, again, multiple different things. You just want to note it, but it could be a sign of liver cirrhosis. It can even be a sign of liver or lung cancers, and also alcohol use disorder. It essentially comes down to hormonal imbalances. And then in the legs, you've got edema, which of course could be a sign of some sort of heart failure. But in terms of the gastrointestinal system, it can be a sign of liver disease or liver cirrhosis because of the lack of proteins in your blood. So all that fluid doesn't really stay in the bloodstream, and it tends to extravasate out into the tissue. All right, now we come to the good stuff, which is the abdominal examination. Again, we start with inspection. So just stand back a little bit, have a look at their abdomen, look for classic things like surgical scars. We kind of discussed this in a previous lecture, what the different types of surgical scars are. So you can have a pretty good guess in terms of what a particular scar could have been due to. Of course, you can ask the patient, where does this scar come from? Do you remember the surgery? But if you have an idea, that makes things a lot faster and easier. You have distension of the abdomen, which can be a sign of potential bowel obstruction. It could be fluid developing, could be a lot of things. Swelling, as I said, similar to distension, striae, as well as asymmetrical movements. So what you can get the patient to do is lie down completely flat, and you sort of kneel down to that level and ask them to breathe normally. And if you notice that some parts of the abdomen are kind of higher than others, of course, that could be a sign that there's a mass there, or it can be a sign of an enlarged organ, what we call organomegaly. In terms of bruises specifically, these are two really high yield important signs to remember. You have Cullen's sign, and I might actually go to a picture very quickly to distinguish between these two. So Cullen's sign is generally around the umbilicus. So you have that anteriorly like here. I've got two images. One is kind of a more subtle version of it. And then you've got the bottom image, which you can really sort of clearly see that there's some sort of hemorrhage or blood underneath the skin. So that's Cullen's sign. And then Gray-Turner's sign is more on the side. So the way that I remember this very easily is if you think about Gray-Turner, So you have to turn the patient onto their side to be able to see this hemorrhage. Whereas in a Cullen sign, if you think about the C in Cullen's, you got like two C's together that gives you kind of the space, which is the umbilicus. So that's the way I remembered it. But if there's another way that you'd like to remember, that's totally fine. What do they represent though? Both of them are hemorrhages, but in Cullen's sign, we're really thinking about some sort of acute hemorrhage of the pancreas. And then in Gray-Turner's sign, because it's around the sides, we're thinking about some sort of hemorrhage in the retroperitoneum, which is kind of going backwards and then going around to the sides. If you look at the umbilicus, surprisingly, there's actually a couple of things that you can tell just by the direction in which the umbilicus is pointing. So if it's pointing down, that's more classically associated with ascites. But if it's pointing up, generally it tends to be due to pregnancy, can be in tumors, and I think also in obese individuals, the umbilicus tends to point up rather than down. And then caput medusae is very similar to what we discussed before with the spider navi. But again, this is around the umbilicus. So you will have these sort of legs coming off. And that's a sign of severe portal hypertension because of that congestion in the portosystemic anastomoses. And this was the Cullen's and Gray-Turner sign that I mentioned. When it comes to palpation and percussion, you sort of do these together, and it depends on which organ. Like sometimes you won't need to percuss an organ, sometimes you won't need to palpate an organ because you just need to do one or the other. Firstly, though, when you are looking at all of the abdomen as an entirety, you want to think about all 9 regions and palpate each of them one by one. So obviously follow a order. So go from left to right in the top row and then do the middle row and then the bottom row. You start soft. So all of them you do soft. And if the patient doesn't describe any pain or discomfort, then you can think, okay, I'll palpate a little bit deeper, because obviously the deeper you palpate, the more information you might be able to get about a particular organ if you can feel it. Now think about the actual organs that you're feeling. So rather than just thinking that, oh, this is the left upper quadrant, or this is the left hypochondric region that I'm feeling. Why are you feeling there? Well, maybe it's because the spleen could be in that area, or it could be that there's part of the stomach in that area. And then similarly in the right upper quadrant, the reason why you might be feeling that region is because there's the liver, the gallbladder, etc. So have some knowledge of the anatomy that you're actually trying to elaborate on. Now, a couple of things just to think about when you're palpating and the patient seems to be a little bit uncomfortable, or they physically yell out in pain. Is it tender? So that's, of course, the sensation of pain that the patient will feel. And there's a good, I guess it's a good idea to understand the difference between guarding and rigidity. So when you feel for a particular part of, or a particular quadrant, and it seems really rock hard and rigid, is it because the patient is expectantly sort of making their abdomen rigid to protect themselves, which is called guarding? So remember, guarding is something that the patient actively does. So they know that this part is particularly painful for them in the past. And so when the doctor comes over and presses on it, they instinctively sort of tighten up to prevent that feeling as painful as it did before. But when it comes to rigidity, this is something that's not actually in the patient's control. So for example, classically, when you have appendicitis, and it's, for example, ruptured, right? So then you have peritonitis, you have inflammation of the peritoneum. That is going to result in rigidity around the right lower quadrant. And that's not something the patient is doing. That's just because of the peritonitis and the inflammation of the peritoneum. So you want to be able to distinguish both of those as best as you can, rather than saying, oh, this is very rigid, which is the classic way you describe most hard objects. Think about whether that's something the patient is consciously controlling or not. Now, when it comes to the organs, again, this is the way I like to structure it. So if you have a different structure, that's totally fine. But I like to think about the organs very specifically that I'm actually looking at. So when I'm looking at the upper right region, we're looking at the liver and the gallbladder. So liver specifically, we start with percussion. Again, it's a very, very big organ. So what you do is you start all the way at the bottom on the right-hand side, and you kind of, again, you know how to percuss. You're hitting your finger on the abdomen, and you kind of go up slowly across the mid clavicular line until you hit a dull note, which indicates that you've hit the organ. In terms of palpation, you do a very similar thing. So what you do is, again, you start on the lower right side, you continuously move up. And what you're asking the patient to do is a very rhythmic process. You're asking them to inspire deeply and then expire or exhale kind of repeatedly. And as they exhale, you're going to move your hand slowly upwards until during an inspiration, you actually feel the liver hitting your hand. Now, I will admit I haven't actually felt any enlarged livers before, so I'm not really sure the extent to which you need to go before you can feel it. Generally speaking, you should still be able to feel the liver even though it's not enlarged, but don't be surprised if you don't, because sometimes it's just very, very difficult to feel. But I would recommend that you practice this motion on an actual patient or on another person. So you need to make sure that you get that rhythm correct. So ask them to inspire. During inspiration, remember the diaphragm contracts, the organs will push down. That's where you will feel the liver if it's close to where your hand is. If you don't feel anything, they expire. You move upwards a little bit more. They inspire again. Does the liver hit your hand? No, it doesn't. Keep moving up. They expire, inspire. You keep following that until you can potentially feel the liver. With the gallbladder, again, you can just palpate the region, and if there's any pain, note it down. But two specific, again, high yield signs that you want to remember is Murphy's sign and Courvoisier's sign. So in Murphy's sign, this is really pathognomonic for cholecystitis. What happens is you ask them to inspire really deeply, you palpate in the region where you would expect to find the gallbladder, and the patient catches their breath in pain. So it's so painful that they're unable to really finish their breath, and that can indicate some sort of gross inflammation of the gallbladder, so what we call cholecystitis. And Courvoisier's sign is where there's no real pain, but you can still feel the bladder being grossly enlarged. And in this case, we're not thinking inflammation anymore. We're thinking that something is compressing the bile ducts, which is preventing bile from draining away from the gallbladder, which is causing it to be enlarged. And of course, it can be multiple things, but statistically, the most common cause would be a pancreatic cancer. Remember how close the pancreas is, or the head of the pancreas specifically, is to the bile ducts. So if you have a growth on the head of the pancreas that's impinging on the bile duct, it's going to cause that backflow and the enlargement. That one is, I know it's sort of weird, like it's not painful, but it's also probably going to be a little bit more dangerous of a condition, because as we know, pancreatic cancers tend to be quite significant and quite difficult to treat. Now, with the upper left, you're really only thinking about the spleen in this case, and a very similar sort of pattern to the way that you did the liver. You're doing percussion, but this time, remember that the spleen tends to actually enlarge rather than the liver, which enlarges downwards. The spleen actually enlarges in a diagonal fashion, which is a bit strange, but it goes from the upper left to the lower right. Okay, so when you're percussing, you want to follow that diagonal pattern. So percuss from the lower right to the upper left until you can sort of feel that dullness, and that's where you've hit the spleen. And then when you're palpating, again, go diagonally from the right iliac fossa to the left upper quadrant. And the reason why is, as I said, you have inferomedial expansion rather than directly inferior expansion of the spleen. And then the other organs are very easy. So when you look at the middle row, you're looking at the kidneys on the flanks. So the way that we do this is ballottement. So if the patient was lying across the bed like this, and I've got the flank between my two hands like this, all I'm doing is this. So they're synchronized together. And if I do feel something sort of hitting my hands, that can indicate an enlarged kidney. Of course, you might be able to feel this more easily, like say, for example, in thin people, and that might not be actual pathological enlarged kidneys. It's just because they have a lot less fat that could be making it difficult to feel the kidneys. So you want to use your clinical judgment as well. But just, in general, it's a sign of enlarged kidneys. And then finally, the aorta. So you want to be looking around the umbilicus. Sorry, that shouldn't say para-umbilical. Para-umbilical is more for the renal arteries. When it comes to the aorta, you're just looking about 2 to 3 centimeters above the umbilicus. I'll make that correction in the slides. And if you feel an expansile pulsatile mass, those words, as soon as you hear that, or as soon as you feel those characteristics, you're thinking an abdominal aneurysm. Okay, so you're thinking aortic abdominal aneurysm, which is important because those aneurysms have a high risk of rupturing, which is like a surgical emergency. Okay, very, very high mortality. And then finally, in the bottom row, you really only have the bladder that you need to deal with. So you're doing, again, palpation and percussion. The way that I like to do percussion for the bladder is I go from one side of the abdomen to the other in the lower row. And you should be able to, like if you have a full bladder, then you might, when you palpate it, you might be able to feel the bladder a little bit, but generally you shouldn't be able to. When you percuss it, though, you might be able to hear some high-pitched sound just because you've got a lot of fluid in that area. And then finally, shifting dullness is this very specific sign to locate ascites, which is basically, if you think about edema, it's just abdominal edema. So the way that you do it is you take, like the patient is lying down normally, and you percuss their abdomen from one side to the other. So if you're starting from the left, you go percuss, 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 all the way to the right-hand side. And if you feel any, or if you hear any dullness, remember that normally things should, because most of your gut is just kind of like gas, right? You shouldn't really be able to have any dullness. If there's any dullness anywhere, you're thinking, is this fluid? Right? Could this be fluid, or is this something else that I need to investigate further? If you think it's fluid, you want to mark that area specifically, then get the patient to roll over to one side and then wait for 30 seconds. And the reason why you do that is because if it's fluid, gravity will pull all that fluid down to the other side of the abdomen. Okay, so say for example, you felt the dullness on the left-hand side of the abdomen, you ask the patient to roll over to the other side, it should all move onto the right-hand side in about 20 to 30 seconds. Then you want to repercuss on that same sort of area that you marked. And if you now hear a different sound, so instead of being dull, it's now resonant, that means the fluid has all moved to the other side. And that's a positive sign, which indicates there's fluid. Okay, so that's if you're thinking about a positive shifting dullness, it has to be that you've marked the area. Originally, it's dull because of fluid. Then you move the patient, and now it's resonant because the fluid has escaped because of gravity. Okay, hope that makes sense. And then finally on auscultation, not a lot to do here. You want to just kind of generally auscultate over the bowels, so basically all over the abdomen. Normally you should hear some soft and gurgling sounds. I'd encourage you to try this on your own. It does sound a bit strange and funny. If you do hear a high-pitched and tinkling sound, again, those terms are highly pathognomonic for a bowel obstruction. So either a small bowel obstruction or a large bowel obstruction. And then you can have splashing or slushing sounds, kind of goes hand in hand with the obstruction. Generally, it's where you've got gas or fluid that's trapped proximally to the obstruction. You will hear those sounds. And then finally, bruits. So you listen to aortic bruits, again, 2 or 3 centimeters above the umbilicus. And then you listen to the renal arteries for any bruits, and those are on either side of the umbilicus. And these can be signs of potentially atherosclerosis, which is causing your turbulent flow through the arteries. Or you can have stenosis, and particularly with renal artery stenosis, that it is one of the potential causes for someone to have hypertension. So we'll discuss that more in renal anatomy, but it's a big risk factor, or it's a potential cause of someone having chronic hypertension. So that's pretty much it. So all these slides will be made available in the next couple of days for you to review. If you do have any questions, or please feel free to message me or put your comments in the CuriousCat if it still works. One big tip that I have is that gastrointestinal examination, it's one that confuses and mystifies a lot of students because there's so many steps to do, so many organs, right? Like with the respiratory exam, you only really have one organ, which is the lungs. Cardiovascular, you only have one organ, which is the heart. But suddenly you get to gastrointestinal and there's so many different organs to keep track of. My tip for that is if you stay systematic and just remember the specific organs, and really the major ones are the liver and spleen. The other ones you can kind of just like remember really briefly that I need to still look at the kidneys, I need to look at the aorta, I need to look at the bladder really, really quickly. Then you should be fine. Okay, so that as well as repeated practice will make you an expert at these sorts of examinations. All right. So thanks again for viewing this video. I hope that you found this helpful, and best of luck for the rest of your studies. Bye.